All right, everybody, welcome to Tuesday topic today being muscle relaxant with NMB and sedation / awareness. And you can see here with this highlighted brain that really part of the focus is on the understanding that when we use paralytic agents without correlating that with objective methodologies for maintaining sedation or amnesia or hypnosis, whatever term you like to use, that individuals can be uniquely and profoundly awake, alert, aware, and unable to move. So it always reminds me of, oh gosh, when I was a young girl, maybe 12 years old, I don't know what my parents were thinking. The original Twilight Zone was on in those days. So in the late 50s, early 60s, the original Twilight Zone. And I remember watching an episode where a person was buried alive. He was paralyzed, but he was still breathing, obviously. And he was very aware, and he was trying to communicate to people around him that he was aware of what was happening, that he was placed in a coffin. Of course, how'd you get into the coffin without having your blood drained? I have no idea. Now I know different, but as a 10-year-old child, watching that was the most terrifying thing I'd ever seen. And I'm pretty sure that's what all of us think about when we think about utilizing neuromuscular blocking agents, is how are we making sure that our patient, A, is not aware, and B, if they are aware, how we can assure that they don't remember what's happened, that they don't remember what's been said, that they don't remember how they felt, that they don't remember their fear, and that doesn't get carried with them for the rest of their life. So that really is the point of today's topic. So we start first with just remembering what a neuromuscular blocking agent is. And the other term, probably the more PC term, is this is a local, not a central, that'd be like diazepam, but it's a local neuromuscular blocking agent, also known as the skeletal muscle relaxant. And that's really the more politically correct term. Rather than saying that we've paralyzed your muscles, we've completely relaxed your muscles. Now we can do that peripherally, and that's done at the NMJ, the neuromuscular junction. So right at the point of nervous system activation and at the receptor plate in the muscle, it's actually blocking the uptake of that nervous system stimulation. That's local or neuromuscular junction. And then, of course, the other way is centrally. And centrally means something that we're using neurologically about GABA or other serotonin that actually is going to affect actual cerebral perception or cerebral stimulation of the motor plates of the neuromuscular junction. So really, really important for us to start with that and to recognize that what we're talking about today is really going to be the peripheral neuromuscular junction, neuromuscular blocking agent, or skeletal muscle relaxer. Now, in general, these agents were born in order to facilitate during surgery neuromuscular relaxation so that it's easier to intubate patients, to control any kind of movement, to prevent patients from moving, and at the highest level, to prevent any diaphragmatic discordance with your mechanical ventilation. Now, those of us who've been around for 10, 15, 20 years will remember that it was quite frequent when patients were intubated in the ICU, if they had any dysynchronicity because they had diaphragmatic contraction, they were stimulating, turning on the vent breath in assist control mechanical ventilation, or in those days, intermittent mandatory ventilation, which we don't do any longer. We do SIMV, but not IMV. But in those early days where I don't think we understood very well ventilatory strategies, we would actually paralyze people's diaphragms so that they would not encourage taking breaths, and we could easily control them with our mechanical ventilation. Now, I just want to mention, in today's world, you cannot control patients' diaphragms with the ventilator. You can only control a diaphragm with a neuromuscular paralytic agent, and that's going to be at a relatively moderate level. So that's really quite important for us to remember, and we'll discuss that just a tad bit in a little while. So if we just look at our central acting agents versus our peripheral acting agents, centrally, of course, is working in the cerebral vault. It causes CNS depression. It can cause very significant paralysis or flaccid paralysis. And in general, we don't use these agents for intubation or diaphragmatic control or in the ICU. What we typically are going to use are peripherally acting muscle relaxants. Those are blocking, remember, the transmission at the neuromuscular plate. That causes muscular paralysis, and depending on the level that you are using, how high the level you're using is, can also suppress completely voluntary muscle movements. Now, this is almost always given intravenously and is almost always for short-term use. So really important to remember that the primary method in which we use these agents is intravenous. There's only one agent that you can give intramuscularly, and that is succinylcholine. And rarely do we give that intramuscularly, but we can if necessary. Okay, so things we think about with neuromuscular blocking agents is we think about how quickly they're going to work, how long they're going to stay around, how do they get broken down and eliminated from the body? Do they eliminate by themselves, like Cisatracurium doesn't require renal function or liver function? Almost all of our other agents do require renal function or liver function or both in order to be eliminated. And what kinds of side effects do patients have when we're utilizing these agents? And then that also, of course, brings us to patients who are at more risk for long-term muscle dysfunction and loss of muscular tone because of their secondary issues and injuries and comorbidities. So very, very important for us to remember that in some of the patients that we might consider this utilization, and especially rapid utilization, like sepsis or patients with ARDS, patients with renal failure or liver failure, that these underlying medical conditions are going to significantly, profoundly impact actually the duration of action and the route of elimination. So that's really important as we move forward and as we give these agents to patients in clinical practice to really understand that secondary effect that this drug is going to hang around longer or it's going to be eliminated more rapidly depending on the patient and depending on the situation, which then is going to require us to be more vigilant and to reduce dosing or to increase dosing and maintain an increase in dosing. So one of the places I find this to be the most important is in patients who are on CRT and really thinking about CRT elimination through the filter of agents and how we may have to upload our agents and dose at a higher level because of more rapid clearance. Okay. Just a simple visual here of the motor end plate. This is what we're actually blocking when we use neuromuscular blocking agents. And just like any other agent that you give, you're giving a dose of agent to saturate receptor sites. The higher the dose, the more the receptor sites are going to be saturated. And then just to remember that some patients are going to have desensitized receptor sites, patients who have neuromuscular disorders, patients who have diseases like Guillain-Barré or myasthenia gravis, they're going to have alterations in their motor end plates, and they're going to have a different level of response to neuromuscular depolarization agents. Now, most of the agents that we use actually are blocking the uptake of acetylcholine. So acetylcholine is the neurotransmitter for nervous system stimulation of the skeletal muscles, not like sympathetic epinephrine and norepinephrine. Here it's acetylcholine. And acetylcholine actually activates the muscle plate, and then it is recycled and republished, reactivated, recycled, republished, reactivated. And so when you think about disorders like myasthenia gravis, you may or may not have much familiarity with it. That is a process of the rapid degradation without functional recycling of acetylcholine. So the reason I want you to think about myasthenia gravis, which typically with myasthenia gravis, that is a descending paralysis starting at the head and then descending down to the diaphragm. When you think about using a neuromuscular blocking agent, a skeletal muscle relaxer that is peripheral, it's almost operationally like creating myasthenia gravis because you are blocking the uptake of the acetyl, for most of those agents, you're blocking the uptake of acetylcholine. So even though your patient makes acetylcholine, they cannot respond to it, and therefore they have muscle functional loss. Now that can be short-term, it could be longer term, particularly in comorbid patients, and of course, heightened significantly in patients who are on corticosteroids. So we're going to consider all of those things. You might not be thinking about them. Your anesthesiologist should be thinking about it. Your medical team should be thinking about it, but you also need to advocate for your patient when you're talking about the utilization of neuromuscular blocking agents. Now, there are two types of peripheral neuromuscular blocking agents. Again, I might say skeletal muscle relaxer, neuromuscular blocking, neuromuscular antagonist, all those things are going to be correct. First and foremost, there's one that acutely depolarizes the cell and keeping it in a depolarized state. So similar to making the heart depolarize and maintain its depolarization, we're going to do that in the skeletal muscles. And there's only one that we use clinically, and that's succinylcholine. Succinylcholine has a lot of great attributes, and it is the only agent that can be utilized in case you've lost IV access and you must control the patient's upper airways and their trachea so you can rapidly intubate. You might choose succinylcholine in a lot of those situations, or your physicians choose it, and it will be the only agent that you can give intramuscularly. So that's going to be quite important. This is a depolarizing agent. We're going to look at the difference in those two types of agents. And then we talk about the non-depolarizing, which actually are a delayed response, ultimately the absence of response to acetylcholine. So what that actually means, the difference is that I'm going to depolarize the muscle and sustain it in depolarization, or I'm going to allow the muscle to depolarize, but it's going to have a degraded response. That's the non-depolarizing agent. And we have short actors, which we are not using in the clinical arena. They may use them in the OR. It depends on the patient and the case. We don't use those. Typically, we're using intermediate actors, and the most common intermediate actors that we use in our hospital situation is Rocuronium and Cisatracurium. And remember, Cisatracurium is actually going to be a preferred agent because it naturally breaks down in the blood and doesn't require renal or liver elimination, which makes it a very perfect agent with critical patients who have lots of problems because of the natural degradation in the plasma over time and not having as many toxic metabolites or the requirement for renal or liver clearance. Typically, we don't use Cisatracurium. Some of us probably use Rocuronium. A lot of us may use it a lot, but the preferred intermediate actor is going to be Cisatracurium. And a longer actor will be Pavulon or Pancuronium, which you will rarely see unless you must keep somebody in a paralyzed state for a longer period of time. So initially, when ECMO was started, all those patients would be paralyzed. They'd be paralyzed for a long time. Now we get ECMO patients out of bed and walk them with their ECMO cannulas. So goes medicine and evolution. So again, 15 or 20, 25 years ago, we were very free with neuromuscular depolarizing agents. Or non-depolarizing agents. Very frequently, you'd have your intubated ventilated patient on paralytic therapy, patients who were getting rotoproned or patients who were being proned. Even recently, you might see those patients on paralytic therapy. But the tendency today is to limit this as much as possible because as we prevent the muscle from moving, so goes the muscle, and the muscle will degrade. So as the muscle degrades, what you're looking at is every day that patients are on paralytics is going to add up to a week of muscle recovery time. So then, and that's just a simple equation. It's not exact. Some patients it'll be a little less, some patients it'll be more. But we have to think about this when we are advocating for paralytic therapy for our patients, is that the biggest concern in today's world is that it prolongs recovery. That's one of the biggest concerns. Okay, don't forget, when you join a Zoom, please mute yourself. Okay, so again, remember, the kind of decision that's being made at the bedside is what is really going to be the best relaxant for my patient? How quickly is it going to have an onset? Do I need to do a rapid sequence intubation? Is this going to be slower? Do I have time? Do I have time for the drug to take effect? Do I have to rapidly mobilize and have the airways relaxed and the larynx relaxed? So that's the first decision that you're going to make, or your anesthesiologist or your medical co-partners are going to make, is really based on how rapidly it's going to act. And then thinking about, is this only for that short period of time, or am I okay if it's going to persist for a little bit longer? So marathon meaning I'm going to run a long distance, or is it a 1K race, a quickie? I just need to intubate, then I want that agent gone. I don't want to paralyze my patient for any length of time. And then always remembering about this synergistic pattern of medications that we use that actually can facilitate these agents. And I'll give you a list of them. The most common one that we see that we utilize in the ICU environment that actually prolongs or exacerbates the effect of paralytic agents is amiodarone. Hemiodrone is a fantastic drug, but it's got a lot of secondary effects that most of us don't think about when we're starting it. And we're very free with amiodarone. The only thing you give more freely is lactated ringers. Amiodarone is something you add on patients, really, I kind of think a lot of times we add on patients whether they need it or not. And amiodarone, because of its effect on the potassium channel, profoundly prolongs the effect of your neuromuscular your blocking agents. So we really do have to think about it. And we do want to think about medical conditions or concerns. So let's start with SUX. SUX is pretty unique. Succinylcholine is pretty unique. It is the only depolarizing agent that we use clinically, either in the OR or outside of the OR today. It's the only one. And we like it because it's the most rapid onset. It also is the most rapid offset. So it's a very short term dose. And that's why we really want to use it. It immediately paralyzes the vocal cords, the larynx, and causes relaxation of the airway. So in generalized situations where I have to have a rapid sequence intubation, succinylcholine is fantastic. It's beautiful. And again, remember, it's the only agent that we can give IM. So that's really significant. These are some really significant benefits to the utilization of succinylcholine. So, I've had a lot of requests for this. I know that I've been out of the hospital for the last week with COVID. Today is my first day back. There's no one in this very large room that's got good aeration. So I took my mask off because I can barely breathe anyway. And with the mask, it's pretty bad. I am 9 days post my COVID positive. I tested negative last night. I really don't have any symptoms and I'm wearing a mask. So don't run away from me in the hall, but keep your distance. And, I've had a lot of requests for this, but I just put it together during lunch break today. So please forgive me if I have some repetitive action because part of that is related to my brain fog. I'm just asking for forgiveness. Okay. So here's the thing though, SUXY, got my SUXY back, baby. SUXY side effects, and they're pretty significant. So we need to always just be aware of the side effects of succinylcholine because it's a depolarizing agent. What it does is it causes acute depolarization, and that actually can present with what is called fasciculations, which is the inability to kind of control that muscle movement, fasciculations, the release of a high degree of potassium promoting very significant hyperkalemia, and a really profound cardiac effect. And that cardiac effect may present with bradycardia, junctional escape rhythms, or complete sinus arrest. So I think the thing to remember is this is a really great agent. It's a really great agent, but we have to be very aware that can have some pretty significant effects, okay? In patients who have short-term use of succinylcholine after succinylcholine has been eliminated, they may have very significant muscle weakness for days, and that may actually prolong even beyond days. It could last weeks. Sometimes you actually will see, because of this continuous depolarization activity, that the patient may present with malignant hyperthermia. And, you know, that's really a great topic. We might talk about that on Thursday. If we've got a good case for malignant hyperthermia, maybe we'll talk about that. But it's a very common co-contributor to malignant hyperthermia, which, as most of you know, generally raises its ugly head in the operating room after administration of anesthesia. And it is really related to this continuous depolarization, the release of potassium, and presents as this malignant condition of cellular loss. Now, that cellular loss actually, of course, is going to promote the release of the iron pigment in the cell. That's called myoglobinuria. You will not see myoglobinuria without actually how we would term that is, might be malignant hyperthermia, but the presentation itself is rhabdomyolysis. So myoglobin in the urine is seen in rhabdomyolysis, where you are lysing your muscle cells, and you lyse your muscle cells when you have this acute, active, aggressive depolarization, which, remember, succinylcholine is the only agent today that we use in the depolarization category. So it is quite common. Now, that can also increase kind of eye bulging and intraocular pressure, probably not much worse than it is if patients are dysynchronous with the ventilator. It can cause gastric rigidity, which means the gastric pressure will go up. That may worsen reflux and cause some other secondary problems. And more common in peds than in adults, very common to have masseter. So the muscles that actually control the jaw can become rigid. And then that is a predictor, particularly in the pediatric population, of subsequent malignant hyperthermia. Okay. More issues with succinylcholine. So thinking about individuals who have up or down regulated acetylcholine receptors, we just want to remind ourselves that individuals who have Guillain-Barré, patients who have spinal cord injuries, strokes, burns, sometimes with sepsis, patients who are chronic beta block users, those patients may upregulate their acetylcholine. Now, I want to make sure we appreciate and understand what I'm saying here. So if I've got a high degree spinal cord injury, I have above C5, I actually stay alive because I don't have sympathetic traveling down my spinal cord. I've severed my sympathetic fibers. The only way that I stay alive is through the upregulation of acetylcholine and through the upregulation of my circulating hormones. So these are upregulated in these patients. And in patients, like I talked about already, myasthenia gravis, patients who have anticholinesterase poisoning or organophosphate poisoning, they're going to downregulate their acetylcholine receptors. So what you're going to see in those patients, myasthenia gravis, anticholinesterase poisoning, or patients with organophosphate poisoning, is they're going to look like they've gotten overdosed with neuromuscular paralytics. In myasthenia gravis, it's a much more progressive, starting at the eyebrows and then descending down, getting a hoarse voice, and then ultimately reaching the diaphragm. But with the other two issues, the anticholinesterase and organophosphate, it's going to be global, and it's going to be very much looking like your patient's been overdosed with a neuromuscular agent. So really, really important for us to appreciate that when we're talking about a denervated muscle, that means somebody who's lost their muscle function, right? They tend to have a very high degree of choline or acetylcholine, a very high degree of potassium availability to maintain their muscle function. Okay. I think always really, really, really important for us to appreciate with succinylcholine. So looking here at this, I think this is such a lovely, lovely visual. So we're looking at patients who received succinylcholine, okay? Here's my patient's arterial potassium pre-succinylcholine, and here's my patient's rhythm. Okay, so it's a little bit irregular. Maybe I have some PACs, but it's not really atrial fibrillation. It's not really that abnormal. 2 minutes after receiving succinylcholine, the patient's potassium is 8.3, and you're going to start to see some degradation of their rhythm. 5 minutes after succinylcholine, and this is patients who have acquired diseases. So they already have this disorder and then they got succinylcholine. But I just want you to really see what's happening to this patient. So this might be a patient with renal failure who's already got some problems with regulation of potassium. 5 minutes after, the patient's potassium is 9.2. 23 minutes after, and also receiving defibrillation, potassium is 7.2. 24 hours after, the potassium is 4.2. So you can see that what happens with succinylcholine is this continuous depolarization, which is the release, because the cell is depolarized, the release of cellular level potassium out into the serum. And you can see the very significant and profound effects that you have on the myocardium. Now, you are rarely going to see this. This was a study and it was an evaluation. And this was a dog, not a human being, that there was some testing done in this dog, which still seems really cruel, but it wasn't like your grandmother or your next door neighbor. And it was research looking at the effect of succinylcholine on arterial potassium after administration of succinylcholine and correlating that together to electrical rhythms. I found it to be quite fascinating. And just to remember, because you are continuously polarizing the muscle, you're going to release potassium. Now, you're not going to see that with the non-depolarizing agents. You only see that with succinylcholine. So before administering succinylcholine, it is beneficial to know what the patient's potassium level is if you have time. If you have time, you may not have time because you're doing a rapid sequence intubation. Now, if we look at non-depolarizing agents, and that's everything else that we're using, and we looked at those before, short actors, intermediate actors, long actors, and in general, we're using intermediate actors. These are really interesting because they compete with acetylcholine, but they don't block that acetylcholine. And that's what acetylcholine is, what allows that muscle to relax. Okay, so they don't cause depolarization, but they protect the muscle, the receptor sites in the muscle, from depolarization by acetylcholine. So that causes flaccid paralysis. So with non-depolarizers, with depolarizing agents, they're going to have almost tetany of the muscle. The muscle is going to be very tight and terse, and that's going to be succinylcholine. With everything else that we use, the non-depolarizing agents, the muscles are going to be more flaccid. And there's a lot of variability in responsiveness that's related to your patient's temperature, to their volume status, to their age, and by the way, their gender. Much more common to see problems with non-depolarizers in women and women over the age of 65. Oh my God, that includes me. Please be careful with me if I come under your care. And just really, really important to remind ourselves of, again, about liver and renal function, also central nervous system function or dysfunction, and the state of the circulating neurotransmitters. And then you can see right here all of these different agents that will enhance the effect of that neuromuscular paralytic agent that is a non-depolarizing agent. So that's going to be the ones you use the most: Cisatracurium, Rocuronium. Those are the ones you're going to use more commonly. Not so much for rapid sequence intubation, but for intermediate action, 4 hours, 6 hours, 8 hours. A little bit longer, you need to control the diaphragm. Patient is using way too much oxygen, you're trying to reduce metabolic demand for oxygen, you might be using a non-depolarizing intermediate actor. So you got to just think about the kinds of things that enhance the effects of that we talk about, that we're using. So antidysrhythmic agents, particularly potassium and sodium sparing agents, aminoglycoside antibiotics. We're not really given local or volatile anesthetics in the ICU. We're only going to worry about that if the patient's in the OR. And dantrolene, which is most commonly going to be used in individuals who have spasticity. You're not going to see it very often unless your patient is a chronic spinal cord patient. Patients who have a low magnesium level, that's also going to affect the effect of the agent. And then diminished effects related to hypocalcemia, to corticosteroids, to anticonvulsants, any kind of burn or cerebral vascular accidents. Okay. So just wanted to say effects from the agents are either allergic, related to histamine mediation, or related to the actual receptor sites. Don't worry, cardiac muscarinic or nicotinic receptors. I'm not worried about that. All I want you to remember is that neuromuscular agents are responsible for about 50% of anaphylactic reactions when we're talking about anesthesia administration. So a lot of folks will say, well, I'm not giving anesthesia. You're giving cisatracurium or you're giving succinylcholine, you're giving anesthesia. That's anesthesia. You're approved for it, but you need to be very aware of that. And succinylcholine is the most common anaphylactic response. So again, just want to make sure you remember that. Succinylcholine is the most common neuromuscular blocker that can coordinate to an anaphylactic response. So just be prepared. You just need to be aware. That's all you need to do. You don't have to diagnose. You don't need to write the order. You need to be aware that about 50% of patients who get succinylcholine or patients who receive rocuronium may have a histamine-mediated anaphylactic response. So really, really important. Now, it's going to be very relatively rare for you because you're using very low dose over time. You're not doing anesthesia and inhaled anesthesia, which will exacerbate these agents, but you do need to be very aware. So I gave you some dosing, but you've got a critical care pharmacy book. You're not really that worried about me telling you about dosing. Just to remind you that most of these agents are actually cleared through the liver and the kidney. And if we just take a look at this agent, pancuronium, which you typically are not going to be used, is pretty rapid onset, 3 to 5 minutes, and it's longer acting, 60 to 90 minutes. So you're going to maintain that continuously, so you'll have continuous action. Rocuronium, pretty rapid onset, 3 to 5 minutes, and it hangs around for about 35 minutes. It does have an active metabolite, so it takes a little longer to clear and requires, of course, liver and kidney excretion. Rocuronium, this is the only agent, non-depolarizing agent, that actually has an FDA label approval for rapid sequence intubation. So frequently that will be the agent that you use. This is pretty rapid acting, 1 to 2 minutes, and it hangs around for 20 to 35 minutes. And that's as long as we have good clearance, as long as we have functional gallbladder clearance. And when we look at the bile of individuals, we see that if you have gallbladder failure, you will not actually have the activation and the clearance for rocuronium, which requires basically the conjugation of bilirubin. So sorry, I'm sure you don't really care too much about that. This is the one you might care the most about. Rapid onset, 3 to 5 minutes, hangs around for 20 to 35 minutes. And remember, Cisatracurium. So in general, that's going to be the recommended methodology for longer intermediate action when you're using neuromuscular blockers, because it has very little hemodynamic effect and because it is not correlated to histamine release or any anaphylaxis. And again, remembering that this is a fantastic agent, Cisatracurium, Nimbex, for us to use in anybody who has renal failure or liver failure, because it doesn't matter what the kidney or the liver are doing. The clearance is principal in plasma, natural breakdown within the plasma. That makes it a really great agent. So again, what I would recommend overall in discussion, succinylcholine for rapid sequence intubation, being aware of the fact that it's a depolarizing agent, that potassium may go up, that the patient may have vesiculation. And if you have a patient who has had a history of malignant hyperthermia, it's very common after succinylcholine for those patients to actually have malignant hyperthermia again. With Cisatracurium, Nimbex, what we're going to say is in general in the medical ICU, this is going to be the drug of choice if we're using neuromuscular depolarization for any intermediate process, because it does not require renal or liver clearance, and because it does not have an associated anaphylactic response, which could make conditions like sepsis significantly worse, putting on the loss of vascular tone and then histamine release, promoting more loss of vascular tone. Now that brings me to, I think, what most people really wanted to talk about, which is peripheral nerve stimulation, train of 4. But if you don't understand the agent, you can't really understand what train of 4 is about, why you're using train of 4, what that means to you, what you're trying to elicit, and what you're trying to understand with train of 4. So I'm not going to spend too much time on this because really most of us should already know a lot about it. So first, just remember, why are we putting a patient on a neuromuscular blocking agent? And what are our expectations with that agent? How long is it going to hang around? How long are we going to keep the patient on it? And how we're going to evaluate that we are not completely deteriorating your muscles, which means you never want to see absence of all electrical activity at the muscle. That's what Trainer 4 allows you to do. It allows you to assure that you still have some muscle stimulation, because even a small amount of muscle stimulation is going to help your patient maintain their muscle function over time. So that's why we really look at Trainer 4 to make sure that we're not overdosing our patients with neuromuscular blocking agents. Okay. So really, really important to remember that I'm just making up a number, so don't use this in your discussion, but I have 100 neuromuscular junctions that activate 100 muscle fibers. And once I've activated those muscle fibers, the rest of the muscle becomes activated. So what we're going to do is we're going to saturate somewhere around 50% of those muscle fibers with our agent. That's what the dosing is about. I want to saturate a certain number of muscle fibers, but I still want to retain muscle function. So when I look at Trainer 4 and I say I want to see a 50% loss, that means I'm looking at 50% degradation or 50% disappearance of neuromuscular response when I apply an external stimulation. I never want to see full absence, because with full absence, that means I have no muscle activation at all. And if I have no muscle activation at all, that muscle is going to be degraded immediately. We're going to use that muscle for protein. You're going to break that muscle down. When you paralyze the diaphragm, you break down the diaphragm. That patient now has to rebuild their diaphragm in order to come off the ventilator. And it's going to take a lot of time for them to do it. You actually cannibalize your own muscles if you don't have electrical stimulation. That's why you'll look at Trainer 4. That's what's so important. So remember, what we're doing when we measure with the Trainer 4 is that we are actually trying to look at the parallel decrease in muscle fibers or neuromuscular junction that are blocked and how that's going to affect our patient. So really important to think about the strategy of Trainer 4, which is going to give 4 supramaximal electrical stimuli at a maximal voltage every 0.5 seconds. So about 2 hertz every 0.5 seconds. So 4 electrical activations, okay? We're not really talking about this continuously. We're talking about it in groups of 4. What we expect to see with non-depolarizing agents, so that's everything except for succinylcholine, what you expect to see is a fade in responsiveness. So with the first stimulus, you'll have muscle response, and that muscle response will decrease with the subsequent stimuli until basically it's disappeared by the 4th stimuli. Now, there are 2 things that we talk about with Trainer 4. Most of us just talk about the disappearance of the muscle activity related to the 4 stimuli, but really, really important is to look at first response and last response. So first response and 4th response, that's called a train of 4 ratio, okay? So if you don't have neuromuscular paralytic on board, you're going to have the same activity for all 4 stimuli. That means the 4th response is the same as the first response. But as you are blocking the fibers, those responses are going to degrade when we're talking about our depolarizing or non-depolarizing agents. So if you take a look here at your agents, so this is list 0, 1, 2, and 3. This is normal. And now I've added in a non-depolarizing agent. And so I'm looking at 1, 2, and 3. And what you see is that faded response. Stimulation stays exactly the same. This is looking at continuous stimulation, but it's just such a beautiful visualization of what you're expecting to see with Trainer 4. So you are not necessarily trying to see that there's no activity, but that the activity is significantly diminished. So this is very subjective. You're really observing the patient. You apply the 4 stimuli. First response is active, and then each response following fades. Whereas with the depolarizing agent, actually, you basically see the absence of response, and you should see the absence of response immediately. You don't really wait for that. And it's very, very important when we're talking about that responsiveness. So these are actually minutes, they're not responsiveness, but you're looking at how that response degrades over time. So depolarizing agents, again, the only one we're using is succinylcholine, is not a fade, it's just an absence. So the more agent I use, the more absent I'm going to see response, and I'm going to see the absence in the first response and the last response. But in the non-depolarizers, which are basically what we see, is we see that faded response. Okay, this is different activity, different electrical activation in terms of hertz. So this is normal, and this is early initiation non-depolarizer, and then increasing the continuous agent, and you're seeing that that response fades away, right? So very little response to almost no response in the train of 4. So you really have to know what agent you're testing. First of all, are you testing a depolarizer or non-depolarizer? Most of you are not testing depolarizing agents because you're using that for short-term sequencing. But with intermediate agents, you are going to use train of 4 to evaluate that patient. So what you're looking at in train of 4 is a degrading or decreasing responsiveness over time. You're expecting to see first response to be normal, and by the third response, you should see degradation. You may see absence of the visible response on the fourth stimuli, and that's going to be acceptable. Typically, orders are written for train of 4 to have 2 of 4 activities visible to the naked eye. So I'm applying the train of 4, I'm giving you the stimulus, and I expect to see with the first application and the second application some muscle response, and then see that actually disappear from the naked eye. And that's typically how train of 4 is written. Train of 4 in general is not written for you to have zero responsiveness. And that's going to be really, really important when you're talking about application of neuromuscular paralytics. Unfortunately, it's a pretty difficult science to achieve exactly what you want in train of 4. So the thing that's not going to be as difficult, although still somewhat difficult, is actually paying a lot of attention to the patient's awareness of what's happening to them. Okay, so I want to make sure we appreciate awareness. When we talk about awareness, we're not talking about your ability to do complex math. We're talking about being paralyzed, but not adequately sedated with adequate hypnotic agents. So you may not even feel that anxious, but you are really aware of what's happening. You're aware that you can't move. You're aware of the conversation about you. You're going to remember what's been said. Ooh, do you believe how big this woman's boobs are? Ooh, she really smells bad down there. Hey, I heard you had a hot date last night. What happened? Your patient's going to hear that. I mean, you're human. Well, I would love it if nobody ever said anything negative around a patient and didn't have any personal conversation. We're human. We are human. But we don't want patients to actually remember this and be hurt by it and lay in that bed paralyzed, hearing these things, integrating that into their consciousness and remembering this. So remember that awareness must be suppressed whenever you're using neuromuscular blocking agents. And the problem is it becomes very hard for us to subjectively evaluate whether or not you're awake, alert, and aware, because we can't use our standard Ross criteria to say a patient's adequately sedated and has appropriate amnesia on board. That's why we have to use external subjective tools like EEG and evoked potentials or the BIS monitor. Okay, so I know that lots of you come frequently and listen to discussions I've had. I've had a really big discussion about sedation and awareness in the ICU, and I referred everybody to a writer, director, producer named Nancy Andrews. You can look that up, Nancy Andrews TED Talk, TED, TED Talk. And she talks about being a patient in Johns Hopkins MICU. And when you first listen to her, first of all, she's got this really weird flat affect. I don't know if that was the way she was before she was in the ICU or since. She's got very strange kind of flat affect. And she talks about being tortured and what she heard and how she understood it and how people were always touching her genitals and she was sexually trafficked. This is what people are feeling under our care when they are not adequately managed. So this is really important. So when we talk about patients in the OR, like 2 out of 1,000 patients are completely aware during their surgery. Many more than that. There's not an absolute number, but one of the recent studies I looked at was 10 out of 100 ICU patients who receive neuromuscular paralytic are aware of what's happening. That is appalling. That you would be paralyzed, unable to do anything or defend for yourself, and be totally aware. 10 out of 100 ICU patients. Now that's older data, that's from like 2017, so maybe that's a little different now, but probably not that much different. So most of these episodes of awareness are avoidable. So I want to make sure you appreciate what I'm saying to you now. You don't write the orders, but you do implement them. I know for a fact, even in the last year, I've had nurses call me and say the attending physician ordered a neuromuscular paralytic agent. And when I talked to them about sedation, they said they didn't want to give sedation because the data shows that sedation is not, that exacerbates delirium and is causative for a problem. You must not agree. You must not agree to give neuromuscular paralytics without sedation and analgesia. But absolutely not without sedation. You must have sedation when you use a neuromuscular blocking agent. These individuals being aware of what's happening, this actually alters their consciousness, their reality. Many of those persons actually have lifelong detriment, PTSS, PTSD, emotional withdrawal, profound fear, psychosis, delusions for the rest of their life because of what happened to them under our care. So I do know that we have some physicians, honestly, that will put patients on neuromuscular blocking agents and will not agree to sedation. But if they don't agree to sedation, I don't agree to a neuromuscular paralytic. I don't want to get into a confrontation or an argument. I don't want it to be a negative situation, but I'm going to refer that to my pharmacist, or I'm going to refer that up my channel because I don't want to get into a fight. I don't want to have everybody upset. I just want to say I'm only going to do what's really right for the patient, and the patient cannot be aware. So the goal of anti-anxiety or sedation agents here is to reduce their awareness and promote amnesia. That's your goal. That's a little different than when you're using just sedation. You still want patients to be aware. You still want them to be alert and able to communicate with you. You just don't want them to have anxiety. Here, with neuromuscular paralytic agents, you do not want these patients to be aware because this is terrifying for them because they've been paralyzed. So I have a little list just of a few films, but public awareness has become very explicit because there's multiple horror movies that have been produced about being awake during neuromuscular paralysis, most particularly in the OR. So awake, anesthesia, return, under, heartless, and the first really kind of popular medical show after ER, which also ER also had 2 episodes about patients who were paralyzed but aware. Nip and Tuck, New Amsterdam, The Resident, Grey's Anatomy. Every single medical show has at least 1 episode about patients who are aware during receipt of neuromuscular paralytic agents because it's become very popular, because it's profoundly fearful. My colleague today, Shannon Daniel, who's my partner in CRT, said that when she had her second baby and she had to have a C-section, she looked at the nurse anesthetist and said, "Be sure that I am not aware of anything you're doing and that I am not awake." And then I think she followed that with, "or I'm going to sue you," but she was in labor. So, and she knew the anesthetist. So I think they laughed about it, but it is strategically what many people are fearful about when they undergo anesthesia or they come into the intensive care unit. And when you talk with the family about we're using an agent to paralyze your loved one, to stop them from breathing, to stop them from using so much oxygen, all they can think about is, are they aware? Are they awake? Are they in pain? They really don't care that you gave a paralytic. They care about whether or not their loved one is awake, aware, and in pain. So aware of what? So what the most common thing that patients are aware of, even though they may actually have some level of sedation on board, is they are very aware of all the sounds, many of which are unfamiliar, all the bells and whistles of the ICU, but they're also very aware of conversation. Almost 100% of patients that were interviewed in a 4,000 patient study, 100% were aware of the conversation. 85% of them were aware of the sensation of paralysis, that they could not move their hands, they could not move their feet, they couldn't contract their stomach muscles, they couldn't control their vocal cords. Think about how terrifying that must be. And it doesn't matter that you keep explaining to them that you're giving them medication that induces that, they can't remember it. So it induces a very significant feeling of anxiety and panic, helplessness, powerlessness. And many of those patients also have the memory of having pretty severe pain, 9 out of 10 pain. So less commonly awareness of the fact that they're intubated, that they're aware they can't speak, but they're not really aware of the endotracheal tube. They much less commonly have visual hallucinations or delusions, and much less common that they're aware of pain, that they're having pain. It's really much more common, this feeling of anxiety and panic and helplessness and powerlessness. Now, it's really important to understand who is more likely under your care to be aware after receiving neuromuscular paralytic agents. So very important, there's some patient-related, anesthesia-related, intervention-related. Patient-related is the one that we're going to think about very particularly. So again, not thinking about in the operating room, but under our care, patients who are chronic substance abusers are going to be much more likely to be resistant to whatever agent you've given them to promote amnesia or anti-anxiety. They're going to need higher dosing. Women, obese women, women over the age of 65 are going to be more likely to be aware. They're going to need a higher dosing regimen to create amnesia and reduction of anxiety. Anybody who has a minimal cardiac reserve is also going to tend to have much higher level of awareness, and that's really related to their beta receptor sites and the desensitization of beta receptor. But one of the biggest ones is any patient who has had surgery who was awake and aware during anesthesia. That means that they typically are actually clearing their agents much more rapidly. And remember, another thing that can cause rapid clearance is something like CRT or IHD. Okay, so we think about anesthesia related, not our biggest concern, but anybody who just isn't getting enough sedation, they're not getting enough propofol in the OR, they're not getting enough anesthesia. The patient themselves may be hypovolemic, they may be on other muscle relaxants. So if they are on long-term or chronic muscle relaxant, like people who are on Valium long-term or Ativan for anxiety long-term, they're going to be individuals who are likely to be more aware, even though you think you're giving an appropriate dose. Okay, and then any surgeries that are longer surgeries or that are more explicit surgeries, or any surgery that is done on an emergency basis, those patients are much more likely to be aware. Now, the after effects are, of course, what we would call PTSS or PTSD for our patients, that these patients have very significant long-term traumas. And those long-term traumas actually raise their ugly head, most particularly as repetitive nightmares and very heightened anxiety and panic. They are unable to go back to their normal life. They are unable to go back to their normal relationships. They can't relate to their children or their spouses or their parents. And they are often directed by this disorder towards suicidal ideation. So really, really important for us to appreciate the after effects of not controlling our patients. So I just downloaded this recently. I just thought it was so incredible. 1 to 2 in 1,000 patients gain awareness during surgery, but 10 out of 100 ICU patients are aware during their ICU stay. That's really significant. And out of those patients, about 70% of those patients are going to experience long-term effects. So we got to be sure that we're making sure that patients who are receiving neuromuscular paralytics are not aware and that they don't remember. So unfortunately, subjective evaluation like ROS or CPOT for pain, ROS for sedation, those don't work. Most of us are not skilled at heart rate variability, and those are really difficult to achieve. So those are really not working. Other standard subjective measures, those aren't going to work. So what's been recommended, what we use for most institutions when you have patient neuromuscular blocking agents or skeletal muscle relaxation at the local level, is the bispectral index monitor correlated to achieving a level of sedation. So this bispectral monitoring has been around for quite a while. Most of the data that was published on it was published in the years 2002 to 2006, really looking at the utilization of bispectral analysis. It's basically a modulated small lead EEG. That's basically what it is, a small lead EEG that you can apply at the bedside. And in general, what we want to see is that we can get patients to an optimal depth of unconsciousness or sedation. That typically is going to be an abyss level, which is looking at the brain activity and the frequency of brain activity. You're normally, if you're awake, you're at 100%. We want you to get to 40 to 60%. That's what we're going to titrate sedation to get you to a 40 to 60% electrical activation of your cerebral tissue. So what that actually is going to allow us to do is to help you achieve an appropriate dosing level so that patients, remember, this is not about sedation now. This is actually about awareness and amnesia. You cannot be aware and you should not remember what's been done. And that's why we're going to use something that is an objective methodology to titrate our sedation, our anti-anxiety agents to this level. Okay. Anything higher than this, your patient's aware. Anything lower than that, your patient is getting close to a flatline EEG and complete coma. So we don't want to be too awake. We don't want to be under sedated. So we're looking at this. This is under sedated. You're too awake. Over sedated, you're not awake enough and you are completely suppressed. We don't want you to have either. So we're going to guide you towards this BIS level of guided titration. So this doesn't look anything like the EEGs that we see that have multiple leads. You only have really 4 leads that are placed in bispectral activation. So I don't think that I can do any better than what the original organization that presented BIS monitoring, I don't think I can give anything better than what they've given us in terms of slides to actually help us to evaluate sedation with patients who have neuromuscular paralytics on board. So I'm going to move over to this very short BIS evaluation tool. This is actually was produced by the original holders of the BIS license. And it just helps us to really think about objective titration of sedation. And remember that our focus here is to make sure that you are not aware, that you are not awake, that you do not remember what has actually happened. And to do that in a perfect level of sedation, which will be a BIS level of 40 to 60% of electrical cerebral activity. Now, we can all appreciate what happens when you're oversedated or undersedated, right? And the tendency is in today's world is to undersedate to avoid oversedation, but that isn't going to be the best to do when we've got somebody on paralytic therapy. So it is really important to remember that BIS monitoring allows us to maintain consciousness without facilitating that the patient is awake and alert. And that's really what we're going to do with BIS monitoring. So BIS monitoring is going to give us really a local small amount of EEG parameter processing, measuring the direct effects of our sedation agent on the brain. and it's all in the frontal area. It's a frontal montage. It's really looking at the highly active frontal lobes. So we're not looking at temporal, occipital, parietal, just frontal lobes with our BIS electrodes, which will then give us information that we can utilize to titrate sedation. So when we oversedate, we go below 40. When we undersedate, we're above 60, and it gives us that subjective criteria. So you can see here are your BIS electrodes placed across the front of the head to look at the frontal montage. And we're really only we are only going to evaluate the numeric display. Now that numeric display could be on your bedside monitor if you have communication to the bedside monitor, or to a secondary BIS monitor, which is mostly what we do here. We have a secondary BIS monitor. It can give you some waveform activity, but we're not neurologists. We're not really interpreting that waveform activity. We're going to interpret the number on this electromyograph, which is actually looking at the cerebral tissue. Philips also has the ability to integrate that BIS. We don't integrate it. We use an external monitor, but you can see here, patient's at 70, so he is not adequately sedated. Okay. So this is what we use, the BIS monitor. We don't have the BIS modules currently, and we use the BIS center, which gives us a ground and a frontal montage across the forehead, allowing us to communicate the electrical activity to our BIS monitor, and that is relayed to us both in a digital and a waveform signal. And remember, we're going to titrate to 40 to 60. So patients who are paralyzed, who we cannot look at RAS, we cannot observe them in other ways, we can't communicate with them, we can't evaluate their organized thought, we have to have an objective parameter for titration. Okay, so first and foremost, the sensor is applied very particularly on the forehead, and it's applied at an angle. So number one is centered directly above the nose, 2 inches above the nose. Number 4 is directly above the eyebrow. Number 3 is on the temple between the corner of the eye and the hairline, and number 2 goes in between. And we're going to press around the edges of each circle to ensure that they adhere, and each circle has to be pressed for 5 seconds when you apply. So applying these sensors is very significant in the methodology in which you do it to assure that you're getting the best reading possible. So again, what we're going to remember is if you're at 0, you're at flat line. If you're at 20, you're at burst suppression. That's like anti-seizure, and actually could actually be brain death evaluation. So we don't want to be there. We want to be at 40 to 60. So what that's going to do, this is what's really, really important here. See that? Low probability of explicit recall. In the exact second, you might be aware of what's happened to you, but you're not going to remember it. You're not going to be able to recall it. It's not going to actually transition the area of your brain that actually continuously relives unpleasant events. That's called the amygdala. So what we're really doing is suppressing that amygdalar function to have explicit recall of what's happened to you while you're being paralyzed. We have to paralyze you to control your diaphragm, to control your oxygen consumption, to control your airway, to control your trachea, but we don't want you to remember it, right? We'd like you not to feel anxious about it, but more importantly, we don't want you to remember it, because the remembering of it is what is going to be correlated and titrated to post-traumatic stress disorder. So really, really important. Now we're going to use this for sedation. Even though primarily this was born in the operating room, there is not really strong data that says this is adequate and appropriate for ICU patients. We do use it in the ICU to actually evaluate patients who are on ventilation, who are on neuromuscular block, who are on drug-induced comas, and if we're doing procedural sedation and control, can be very helpful in that situation. And there may be times where your doc says, I want BIS titrated to 20 to 40, because I'm going to do something that's very unpleasant for the patient, and I really need to have a higher level of sedation. But in general, just like they write for a RAS of -2, they're going to write for a BIS of 40 to 60. Now, many of your physicians are not that familiar with the BIS monitor. It's just really important for us to remind ourselves It is a modified frontal EEG, and we're looking at reduction of cerebral activity that then correlates to the level of sedation, and that we want enough cerebral activity that you're awake, but not enough that you're aware or that you're remembering. That's what we're trying to achieve. It's not that easy, but this actually helps us pretty significantly. So again, we're thinking about oversedation, undersedation, neuromuscular block, really difficult and inadequate sedation assessment tools in those situations. And that's why we use BIS, because it really does help us to have a much more focused titration. And again, I'm going to remind you, we don't put patients on neuromuscular blocking agents without some type of agent to reduce their awareness and to promote amnesia. So it's much more like anesthesia than anything else that you do. So I love this, and I think this will be my last slide. So looking at BIS-guided titration results, okay? We're looking at patients who are on control, meaning whatever you're going to do with your infusion of sedation paralytics, your patient is paralyzed, and the control group is whatever you use to titrate your sedation. And then we look at patients who are BIS titrated. So this is cost decrease. I'm not very worried about cost. This is what I'm worried about. 18%, right, of patients have a significant recall of frightening and painful events. And that's on controlled sedation using standard scales, or I just feel good about how much sedation I'm giving the patient. I think that's what's working. Or using BIS for titration, you've reduced from 18% to 4%. That's a 78% decrease in recall of frightening events related to BIS-generated titration. Now, this is just with BIS of 70 to 80. So we're talking about with neuromuscular paralytics, we're going to titrate your BIS sedation to 40 to 60. And that's going to really help us significantly. Okay. So I think that is where I'm going to end for today. But I know that there's going to be a lot of questions. I hope I can answer whatever questions you have. And I'm really happy to open up for any questions. I want to thank you very much for coming today. This is a pretty straightforward talk. It doesn't require quite as much critical analysis as many of the other talks that we consider. But I think one thing I want to be very aware of is that it's fearful to give patients neuromuscular paralytic agents because we feel like we've lost control of understanding what the patient is going through. And indeed, that's exactly right. You've lost control of understanding what your patient is going through. And that's why we have to consider utilizing BIS monitoring in conjunction with neuromuscular agents and trying to apply that in an appropriate situation. Okay, let me just stop the recording.